Good day, my dear postgraduate students. Welcome to Snip, Short Notes in Pathology. And the topic for the day is Sega. This has been asked in some of the university questions. Sega means subependymal giant cell astrocytoma. The definition or the general features are: it is a benign, slowly growing tumor arising from the walls of the lateral ventricles and is composed of large ganglioid astrocytes. Ganglioid, that means it is similar to, and it is a benign, slowly growing tumor. Another important point will be, please do remember, it is associated with tuberous sclerosis. This itself might be a question, we shall revisit it later on. And there are two important things in this. One is a hamartin protein, another is tuberin protein. These two are there in TSC1 and TSC2 respectively. So this is a beautiful article. I would like you people to kindly visit Pathology Outlines, Iman. So diagnostic criteria. Just like your rheumatic heart disease, there are the major criteria and minor criteria. Here also there are a series of major features. So it can be angiofibroma or it can be a ungual periungual fibroma. There can be cutaneous lesions such as macules, nevus, or there can be nodular hamartomas. In the brain, it can be a cortical tumor, subependymal nodule, and also there can be a subependymal giant cell astrocytoma. Cardiac, there can be rhabdomyoma, solitary or multiple, lymphangiomatosis, and renal angiomyolipoma. So many things are there. But one casual look will make me think that most of them are more like a proliferating lesion, a tumor-like lesion, or a hamartomatous lesion rather than a pure neoplasm. So this is another good reference we'll go to. These are the major features. Then what are the minor features? There can be random distributed pits in the dental enamel. Rectal polyps, again hamartomatous, bone cyst. This can be a hamartoma also. White matter migration lines, gingival fibroma, non-renal, retinal, achromic patch, and then Coffee skin lesions, multiple renal cysts. Most of them again point out to some kind of hamartomatous lesions. So the diagnostic criteria will be definite when there are two major and features or one major and two minor features. Probable means one major and one minor. Possible is either one major or two minor or two or more minor. So this is the one. In the last one, there is a chance that there are no major features, but it is still possible. So tuberous sclerosis, these are all the various things you already mentioned. And there can be a coincidence of Sega and tuberous sclerosis in 6% of the patients. Descriptions. The gross description is not much. It is circumscribed, calcified. Only 2 points. Microscopically, it is composed of large polygonal to elongated cells resembling astrocytes or ganglion cells. Ganglion cells, all of us know. It is a large cell with a pale cytoplasm, slightly eccentric nucleus. Abundant fine granular eosinophilic cytoplasm and bright pink cellular processes. The nucleus can be round or oval with prominent nucleoli. There is another variant called as a pseudo-rosette formation. Infiltration of mast cells and lymphocytes can be present. No Nissl substance in the cytoplasm. Nissl granules are absent. And even if there is a presence of mitosis or vascular proliferation, sometimes even necrosis, it does not indicate malignancy. So it is in toto a benign lesion. So this is a philosophy that I found out for the Snip, short notes in pathology. Life is too short to wait. Thanks to WebPath for this beautiful picture. What are you people seeing on the screen? I am finding spindle-shaped cells which are arranged in a fascicular pattern, beautifully described as sweeping fascicles. Also, I am finding gemstocyte-like cells, which are large, round. Look at the eccentric nucleus over here. And immunologically, you find they can be positive for GFAP and other neuronal markers. Some of them have got a vacuolated cytoplasm. It is a low-grade glioma. Another feature is this. A gemstocytic astrocytoma can be a differential diagnosis by itself. Sega is mainly an intraventricular tumor, whereas gemstocytic is basically right in the center of the parenchyma. Sega, there is no infiltrative growth, whereas gemstocyte can be having. And it is less intensely positive for GFAP, whereas gemstocytic astrocytoma can be more positive. There is no increased mitotic activity or necrosis in a case of Sega. Subependymal giant cell astrocytoma. Look at this picture again. Large polygonal cells. There can be occasional mitotic figures which I am making out. Not much of necrosis is there. And there are some cells which are having a spindling. There are several cells which are having a neuron-like nucleus. Look at this one. These nuclei appear to be resembling a neuron-like nucleus, as in the astrocyte. It is a benign tumor, basically grade 1. And some people say it is more of a hamartomatous lesion. They do not undergo a malignant transformation and are easily resectable. So this is one advantage of it. However, the prognostic implications will be depending on two things. One, the location, and two, it is association with tuberous sclerosis. As I had been mentioning in one of my first slides, the molecular genetics will depend on TSC1 and TSC2. TSC1, there is a coding for hamartin, whereas TSC2, there is a encodement for tuberin. These two are important. And these two proteins form a complex that inhibit the kinase activity of M-motor. As a result of which, you find that there can be an increase in the cellular size and an anabolic metabolism development. This is from DermNet. You find that multiple small papules can be seen in the face, etc. Hamartomatous lesions, tuberous sclerosis, are associated with this. And this again is a radiological picture where I am finding it in the subventricular region. Well circumscribed, and opacity indicates that it is probably calcified thanks to neurosurgical atlas. There can be a block of the foramen of Monro in some cases. The diagnosis of TSC has already been established and the relationship known. The patients can be having other features such as some kind of a diminished learning or an epilepsy, etc. Infantile spasm, autistic behavior has also been observed in such cases. The increase in the intracranial pressure can be due to CSF obstruction, which can lead to nausea, vomiting, and lethargy. Wikimedia comments, thanks to this wonderful picture, though it is black and white, and this is a wonderful reference form. The stains are mixed glionumeral phenotype, therefore it can be positive for GFAP or S100 protein, other neurofilament proteins, and neuron associated class 3 B tubule. So these are the positive stains. Negative can be HMB45, whereas it will be positive in a case of other tuberous sclerosis related lesions. The differential diagnosis, obviously because of the location, ependymoma. Sega cells are much larger. Ependymoma, they are more columnar with a blepharoblast-like nucleus. Gemstocytic astrocytoma, intraparenchymal or not intraventricular. And there's a GFAP over here that is positive thanks to Wikipedia. Life is short, and so am I in my classes. Thank you. Meet you in the next class.